Welcome to the first in our series of webinars on the upcoming Office and E&M coding changes. Tonight, we hope to introduce framework, code structural changes, and critical information needed for the January 1st, 2021 Go Live implementation. Our next webinar in early spring will address implementation tips and latest policy updates. Next slide. This series is brought to you by our ACS General Surgery Coding and Reimbursement Committee. Our speakers this evening are Megan McNally, Assistant Clinical Professor and Surgical Oncologist in the Department of Surgery at University of Missouri, Kansas City, and myself, Linda Barney, Associate Professor and Division Chief of General Surgery at Wright State University Boonshoff School of Medicine. Next slide. Here you will find detailed information from this presentation and regulatory information along with other ACS advocacy efforts. Please note the ACS coding hotline is now digital at prsnetwork.com/ACS hotline. We encourage you to make use of this ACS member resource for your coding question. Joining us this evening are members of our health policy and advocacy team, Vanita Majumdar, Lauren Foe, and Jan Nagel. Next slide. Our objectives for this evening include to understand which office and outpatient E&M codes, both new and established, are changing, why changes are being made to the office or other outpatient E&M code set, how physicians should report office or other E&M visits in 2021, to understand when history and physical examination is medically appropriate, and how to document history and physical exam in the medical record. To understand what changes have been made to the levels and elements of medical decision-making, how to count and report total time on the date of the encounter, and how and when to report a prolonged services code. We hope to have some time to address some Q&A at the end. Next slide, please. In and around 2018, the AMA enlisted multiple physician partners to address the staggering impact of increasing administrative burden on clinicians and the care delivery teams. A combined CPT-RUC work group was initiated with the goal of revising office and other outpatient E&M coding, as this code set was utilized broadly across all specialties. The goals were to provide regulatory relief, to improve care efficiency, and to preserve resource-based reimbursement. Key components were removing redundant and unnecessary documentation, reducing audit potential, all with the goal of not introducing payment redistribution between specialties. Next slide. This slide addresses the problems that effective January 2021 we will be addressing. We will be functioning with two disparate coding conventions. One for the new code set reporting that only applies to office and outpatient E&M visits, and the other set which addresses all E&M services not furnished in the office and outpatient setting. Next slide. So you can see in this slide that the new patient visits and established patient office visits are listed to the left, along with the new prolonged services codes. On the right side, you see the set of E&M services that are not furnished in the office and outpatient setting, and these include everything else we do: hospital inpatient visits, observation services, consultations, both outpatient and inpatient, emergency department visits, domiciliary rest home and custodial care, other home visits, and nursing facilities. Next slide, please. So we have to train ourselves to recall the old way and the current way that we address our E&M services, along with this new coding paradigm, which only applies to the office and outpatient E&M services. Next slide. So let's spend a minute talking about history and examination. The number of body systems or areas reviewed and examined need only be performed and documented when medically necessary and clinically appropriate. Billing practitioners do not need to re-enter information about chief complaints and relevant history that has already been captured in the chart by other ancillary staff or by the beneficiary themselves. You simply indicate that such information was reviewed and verified. So unlike the existing H&P documentation guidelines, there are no threshold levels of H&P elements required to meet the code level documentation guidelines. In the new 2021 Office and E&M coding structure, a medically appropriate history and physical is all that is required for the history and physical. Remember, in all other outpatient settings, inpatient services, emergency department, consultation, etc., the existing rules still apply, and there are a range of required services from problem and expanded problem focus to detailed and comprehensive documentations required. Next slide, please. Next slide. So here you can see the new patient and established patient codes. This set of code descriptors applies to office-based, established, and new patient encounters. Again, you can see in the new system effective 2021, only medically appropriate history and/or examination are required. In the old system, there were gradations extending from problem-focused, detailed, and comprehensive levels of history and physical examinations that were required based on the 95 and 97 guidelines. So all that goes away, and it only has to be medically appropriate history and physical pertinent to your evaluation of that patient on that particular encounter. 99211 does not require medical decision-making and is no longer requires a physician or qualified healthcare provider, and usually the presenting problems are minimal. Next slide, please. As you progress down the slide, you see that the level of medical decision-making has not changed from low to moderate to high, as listed on the last slide, and this mirrors the medical decision-making guidelines for new patient. Dr. McNally will emphasize how the level of medical decision-making are different in the new system. This slide shows us that when using time in the new code system, you based on total face-to-face time and non-face-to-face time of the billing provider on the date of the encounter. In all other visits, you cannot use time as a method for code selection unless counseling and or coordination of care dominates the service. So that's a significant change. When using medical decision-making for reporting, both new and established patients require only 2 out of 3 medical decision-making components, whereas in all the other E&M visits that we're accustomed to, established patients require 2 out of 3, and new patients require 3 out of 3 medical decision-making components. And we'll emphasize that more as we go along. Next slide, please. Okay, so code descriptors. Next slide. As you can see in this slide, the 99201 has been deleted, and you will now report 99202 as the first level of code in the new patient system for outpatient office E&M services. This is total time, not only face-to-face time. It is medically appropriate, not problem-focused, detailed, or comprehensive H&P as in the prior coding. The medical decision level is essentially unchanged, and the key components of medical decision-making are essentially unchanged. Counseling and coordination of care is not a factor. Next slide, please. This just goes on to show you the difference between the new patient codes in the existing service prior to 2021 and the new ones beginning in January. So a level 99203 code is low-level medical decision-making. If time is used to code, 30 to 44 minutes of total time is spent on the date of the encounter, up to the highest code level, which is high medical decision-making with code time selection of 60 to 74 minutes of total time spent on the date of the encounter. Next slide. This shows the changes in established patient codes in the new system. Again, 99211 does not require physician or QHP. Therefore, there is no medical decision-making, and the time is usually minimal, as is the presenting problem for which the patient is seeking care. 99212 is straightforward medical decision-making with 10 to 19 minutes of total time spent on the date of the encounter. As you'll see in comparison, in the prior coding structure, there were typical time ranges utilized as an example for the amount of face-to-face time used in a patient counter. But in the new system, these are real-time ranges that are utilized to associate with each level of code. Next slide, please. Again, we're still in the established patients in the range from 99213, which is low-level medical decision-making with 20 to 29 minutes of total time spent on the date of the encounter, all the way up to 99215, which is the upper threshold code for an established service, which is high level of medical decision-making, or 40 to 54 minutes of total time spent on the date of the encounter. When you get beyond the 54 minutes, that's when you enter into the realm of prolonged services, which we'll address later. Next slide, please. Okay, I think we are now on to Dr. McNally and medical decision-making.
Thank you, Dr. Barney, and thank you everyone for listening in. I'm going to delve into the three major components of medical decision-making when using the new coding guidelines and coding descriptors. Next slide. So effective January 1st, the MDM or medical decision-making element categories really haven't been changed. They're still titled data, diagnosis and management options, and risks. However, the element definitions have been changed. When looking at the definitions, there have been extensive clarifying edits to each of these definitions under the new E&M guidelines. Rather than just adding up the tasks focused on the history and physical, we are now defining tasks that are more meaningful to medical decision-making. However, these are not the same as medical necessity, so it's still important to have overall documentation. Make it clear what the medical necessity of the visit is. Next slide. So to go into these elements of medical decision-making a little further, prior to 2021, 3 out of 3 of the elements were required for new patients: a presenting problem, a diagnostic procedure that was ordered, and management options selected. However, effective in 2021, only 2 out of the 3 elements for new and established patients are required. The first element is the number and complexity of problems addressed. The second is the amount and or the complexity of data to be reviewed and or analyzed. And the third is the risk, which is the risk of complications and or morbidity or mortality of patient management. And these were revised to better reflect the medical decision-making process with E&M visits. Next slide. So again, the 3 elements of medical decision-making are outlined here: the problems addressed, the data reviewed, and the overall risk. The problems addressed accounts for the disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter, which we'll look into a little bit further. We'll also delve a little deeper into the data reviewed and analyzed and what that means for various complexity for each of the levels. And then the last element of risk. This is the risk of complications and or morbidity or mortality, and I will make sure to highlight the definition of risk based on CPT. Next slide. So in our levels of medical decision-making, there were originally 4 levels: straightforward, low, moderate, and high. These really have not changed for 2021. However, because the codes have changed, they have adjusted slightly. So again, 99201 was deleted for 2021, and with 99211, as is a low-level visit with a very minimal problem and minimal amount of time, medical decision-making does not apply. Prior to 2021, level 1s were considered straightforward, just like level 2, but that no longer applies with the new coding constraints. Now a level 2 is straightforward, a level 3 is a low, level 4 is moderate, and level 5 is high. Next slide. All right, getting into element 1 a little bit further, problems addressed. I mentioned this earlier, but how CPT defines a problem is a disease, condition, illness, injury, symptom, sign, finding, complaint, or other matter addressed at the encounter. When we look at this based on the level of visits, again, level 1, this is not applicable. Level 2, this would be considered minimal, or 1 self-limited or minor problem. Next slide. We're going to highlight this again. Next slide. So again, this is our level 2 visit. It's a minimal problem, 1 self-limited or minor problem. Next slide. A level 3 visit would be low complexity, and this is 2 or more self-limited or minor problems, 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Next slide. A level 4 would be a moderate complexity, 1 or more chronic illnesses with exacerbation, progression, or side effects of the treatment you might recommend, 2 or more stable chronic illnesses, 1 undiagnosed new problem with an uncertain prognosis, 1 acute illness with systemic symptoms, or 1 acute complicated injury. Next slide. And a level 5 is a high-level visit that includes 1 or more chronic illnesses with severe exacerbation, progression, or side effects of a treatment, or 1 acute or chronic illness or injury that poses a threat to life or bodily function. When documenting which level this is, it's important to ensure documentation of what the side effects or progression of the problem being addressed is noted during that patient visit. Next slide. The next element is our data review. This is our element where we have to review a certain combination from different categories, and this does differ based on each of the levels of the new E&M codes. And we're going to highlight each one of these. Now, the thing I want to also highlight that's important for surgeons in particular is that independent interpretation of a test performed by another physician and not separately reported by the surgeon, for example, interpretation of a chest x-ray, CAT scan, ultrasound, that all meets the criterion for the element as data analyzed. Discussion of patient management or test interpretation with another physician, for example, discussing something with a medical oncologist or discussing pathology with a pathologist, also meets this. However, external physicians cannot be in the same group practice or same specialty or subspecialty. For example, if you review something with one of your partners just to get their opinion, this does not count. It needs to be another independent physician or another physician in a different practice, not just seeking an opinion from one of your partners. Next slide. When we look at level 1, again, this is not applicable. Next slide. When we look at level 2, this is really minimal or no data reviewed. Next slide. When we look at level 3, this is really when we start to get into the data review. And this is considered a limited review of data. So you must meet at least one out of the 2 following categories. Category 1 is tests and documents, and this can be a combination of 2 from any of the following. It can be review of a prior external note from a unique source, like a primary care physician's note. It can be the review of a unique test, like a lab, like a CBC or a CMP, or it can be ordering of each unique test, such as a CBC or CMP or a CT scan. The second category is assessment requiring an independent historian. For example, this might be a pediatric or a demented patient. You must meet one of the 2 categories in order to qualify for the limited level 3 amount of data review. Next slide. Level 4 has a moderate amount of data review, and in this category, you must meet at least 1 out of 3 of the following categories. The first is similar to level 3, where we have actually those 2 categories into one category, but you have to meet a combination of 3. So you have to meet 3 of the following: reviewing a prior external note, reviewing of results of each unique test, ordering each unique test, or assessment requiring an independent historian. Again, these are the same elements from level 3, but you have to meet a combination of 3 of those. Or you can meet category 2, which is independent interpretation of tests. For example, reviewing a CAT scan or an ultrasound or other tests performed by a separate physician or other qualified healthcare professional. Or you can meet number 3, which is discussion of the management or test interpretation. For example, you might discuss a CT scan with the radiologist, or you may discuss with a medical oncologist or radiation oncologist the appropriate care for a patient. Next slide. Oh, sorry, one more example. You can review endoscopy with gastroenterology as a discussion of management. Next slide. So the last element is risk. When we look at the risk, this is really a difficult thing to define. And so I want to kind of highlight what risk is from CPT's definition. So we're going to just blow this up a little bit. Next slide. So CPT has developed an extensive definition for risk, and I'm going to read this out because this is really in the eye of the beholder, and again, important to our documentation to make sure that we stratify the risk to the patient. And risk is defined as this: the probability and/or consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. For example, a low probability of death may be high risk, whereas a high chance of a minor self-limited adverse effect of treatment may still be of low risk. Definitions of risk are based upon the usual behavior and thought processes of a physician or other qualified healthcare professional in the same specialty. Trained clinicians apply common language usage meanings to terms such as high, medium, low, or minimal risk, and do not require quantification for these definitions, though quantification may be provided when evidence-based medicine has established probabilities. For the purposes of medical decision-making, level of risk is based upon consequences of the problem or problems addressed at the encounter when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, and/or hospitalization. Next slide. So again, levels 1 and 2 have minimal or low risk, and so this does not really pertain to them. When we look at level 3, this is a moderate risk of morbidity from additional diagnostic testing or treatment. Some of these examples may include prescription drug management, a decision regarding a minor surgery, decision regarding an elective major surgery without high risk factors, or diagnosis or treatment significantly limited by social determinants of health. Next slide. Level 5 is more of a high risk of morbidity from additional diagnostic testing or treatment. Some of these examples can include drug therapy requiring intensive monitoring, a decision for elective major surgery with increased risk factors, decision requiring emergency surgery, decision regarding hospitalization, or even a decision not to operate or to de-escalate care because of a poor prognosis. And this is something that's important for surgeons to realize, that this is also something that can be of high risk. Other examples may be something that's not as high risk of a procedure, but the patient may have comorbidities, placing them in a higher risk category. Although it's not mandated by the current E&M constraints, but it is listed in the definition of the risk, surgeons can use various risk calculators to define how they're coming up with the level of risk, such as the ACS surgical risk calculator. Next slide. So this kind of just shows the 3 columns of elements in one snapshot, but only looking at levels 1, 2, and 3. And we'll look at level 4 and level 5 on our next slide. But this just looks at the 3 elements to look at those columns and to kind of find out where your patient is falling in when you're seeing them for an E&M visit. Do they have minimal problems? Do they have a limited data review? Do they have a minimal or low risk of morbidity? Next slide. Here's level 4, looking at this a little bit closer, again, looking at the 3 different elements. And again, you decide your level of MDM based on 2 out of the 3 elements of MDM. So as an example, you could have moderate level of problems, but a lower level of data review, but a moderate risk of morbidity, and you would end in a level 4 category. Next slide. So this is kind of an example, what might be a level 4 visit. So one undiagnosed new problem with an uncertain prognosis may be a 50-year-old woman with an abnormal mammogram. Some of your data review may include reviewing her screening and diagnostic mammogram. Some of your category 3 discussion data review could include talking with pathology regarding the HER2/neu status, or discussing treatment options with medical oncology, or even discussing pre-op localization with radiology. And your element 3, which is your risk of complications, would be the decision regarding elective major surgery without identified patient or procedure risk factors. And again, we just kind of use this as a potential example of a level 3 visit. Next slide. When we get into level 5, this is our highest level of MDM. And again, 2 out of the 3 elements. You have a higher level of complexity of problems addressed. You have more data review, 2 out of those 3 categories, and you have a higher risk of morbidity from the recommended treatment. Next slide. Here's an example. So your acute or chronic illness or injury that poses a threat to life or bodily function may be a 70-year-old male with a symptomatic aortic abdominal aneurysm. You need 2 out of the 3 categories for data review. And some of this may be reviewing cardiology's notes, nephrology's notes, ordering an EKG. The patient may be demented, so the family provides most of the history. You may be reviewing the CAT scan and any other prior imaging. And you may have to discuss the case with cardiology because of the comorbidities. And our risk would be based on making a decision for elective major surgery with those additional patient and procedure risk factors, or potentially even emergency major surgery, depending on how symptomatic this AAA is. Next slide. And I just wanted to highlight a few documentation tips, because we all know as surgeons, we make high-risk decisions, but if we don't document these high-risk decisions, then under the current E&M coding constraints, this would not be counted for whatever level you might want to code for this patient. So regarding the problem, it's important to note whether it's an acute problem or a chronic problem. It would be important to use the EPSET acronym, which includes exacerbation of the illness, whether there's progression of the problem, if there's any side effects of the treatment. And if it's an injury, to mention if it's complicated versus uncomplicated. And that, as you can tell with our different problem definitions under element 1, that should hopefully help you define what you're addressing with that E&M visit. Under our data review, you should make note of every unique test or report or note that you reviewed during that E&M visit or prior to seeing that patient. You should make note if you needed an independent historian in that pediatric or demented patient. And you should also make note if you discussed the management or any interpretation of any examinations with an external source. And then lastly, with risk, you really need to itemize the specific procedure risks. As an example, you could say in your documentation, we discussed risks including, but not limited to, and outline those related to the procedure that was recommended at hand. You also should state any patient comorbid conditions that might affect the risk. Another example would be saying that the patient is at additional wound healing risk due to their obesity, their diabetes, their smoking. Maybe they have an increased hernia risk or hernia recurrence risk because of those factors. And all of that would be important to document that in your E&M visit to ensure you're reaching the level of medical decision making appropriate for that E&M level. Next slide. The next section, Dr. Barney is going to take over and delve into the coding changes based on time for the office visits.
Thanks, Megan. So previously it was used as, time was used as a typical reference time for providing face-to-face E&M services. Time could only be used to select a level of service when time was spent in counseling and coordination of care, and that aspect dominated the entire service. Things have changed pretty significantly as earlier this discussion in terms of how we utilize time for coding in the new office-based E&M coding structure. So again, it is total time on the date of service. That includes non-face-to-face time and face-to-face time. Next slide, please. It's generally believed that most physicians will code on the basis of medical decision-making, but there are instances when the amount of time spent does not match the level of medical decision-making required. It still represents a physician, physician and QHP work, and a coding structure was devised to accommodate this. As you can see on the slide, there's a listing of activities that potentially contribute to determining total time on the date of the encounter. This is not only face-to-face time, it is total time on the date of the encounter. Time by other staff does not count towards this time. Time spent performing other services with designated CPT codes does not qualify. And time where the physician and QHP are conferring are only counted as one provider time. This is whoever the billing provider is. Overlapping services do not contribute to the sum of total time. As you can see from the chart, a lot of activities that we utilize in management of a patient encounter contribute to the time that can be used to appropriately document services provided. Obtaining and reviewing separately obtained history, performing medically appropriate history and physical, counseling and educating patients and caregivers, ordering medications, tests, and procedures, referring, communicating to others, documenting clinical information, individually interpreting results and communicating them, time utilizing interpreters, preparing to see the patient, and again, all the time that is required to document the activities that you've performed. Next slide, please. As you can see in this table, we have new patient services in the left column, what prior reporting time was, this typical average time that you used to guesstimate your amount of time in providing a service, and the new reporting time effective in 2021. The time ranges are as noted, And as you will see in the lower, in the last row, the new prolonged services are listed. This is the two add-on codes G2212 and 99417. Both are new for 2021. And they both describe each additional 15 minutes utilized only when reporting with 99205 or 99215, the highest level code in the established and new patient visits. And this code is effective. You can see that these codes are effective at the lower end of the threshold range up to the upper end of the threshold range. So if you're performing a 99202, you have 15 to 29 minutes of total time on the date of the encounter. So anywhere within that range of 15 to 29 minutes satisfies the 99202 level. As you progress up to the next threshold and you hit 30 minutes, that's when you can begin to count the 99203 up to 44 and on up till you get to the highest level of a new patient, which begins at 60 minutes and peaks at 74 minutes of total time on the date of the encounter. And this becomes important when we talk about the difference between the two new prolonged services and when each threshold time can be utilized. Next slide, please. So on December 1st, when the final rule was released, CMS changed the CPT proposed 99417 prolonged service to a G code 2212. And there's a very important difference between how you interpret time threshold points for Medicare and potentially non-Medicare patients. So using the HCPCS code G2212, prolonged office or other outpatient evaluation and management services beyond the maximum required time of the primary procedure, which has been selected using total time on the date of the primary service, each additional 15 minutes by the physician or QHP with or without direct patient contact, lists separately in addition to CPT codes 99205 or 99215 for office or other outpatient evaluation and management services. Do not report G2212 on the same date of service as any of the other prolonged services codes, and do not report G2212 for any time unit less than 15 minutes. So there's no get to the 50% mark and get to utilize this code for prolonged services. You have to use the entire 15 minutes in order to count that as an increment of prolonged service. So there's no midway point. You have to use the entire 15 minutes to count. As you can see, it only applies to 99205 or 99215. You can't use it at any of the other levels because if you started with, say, 99202 and hit 29 minutes and added 15 minutes, you would be within the existing code range of the remainder of the code set. So it can only be used when you code for time, and it can only be used at the highest threshold, which is 99205 for new patients or 99215 for established. You can't tack this prolonged service code on to coding when you've decided to choose medical decision making as your coding convention. Next slide, please. So with 99417, the same rules apply, except you use it when you reach the minimum required time of the primary procedure. So for new patients using 99417, you would hit the 60-minute increment and add 15 minutes of the 60 to 74 minutes. And I'll show this a little bit better in the next summary slide. In the 99417, it's the minimum time in the time threshold range. In the G2212, it is the maximum. So you start at 74 minutes, or you start at 75 minutes for the HCPCS code. You start at 60 minutes for the 99417. Next code, or next slide, please. So here you see established patients. You cannot use the prolonged service code at levels lower than 99215, as 15-minute increments keep you within the code range. So when you get to 99215, you can add the 15-minute prolonged services code for each 15-minute increment that you hit beyond the 40 minutes for the 99417 and beyond the 54 minutes for the the G2212. This has been a little bit challenging to kind of wrap our heads around, because initially when the code was proposed, our interpretation was in agreement with CMS, which was the maximum threshold had to be met before you could apply prolonged services. But now, going forward, at least currently, there are two ways that you code, whether you're coding for Medicare using the G code, or whether you're coding for other payers that may not adopt the CMS rules with the G code. Next slide, please. So as Megan was speaking before, when reporting total time, you still need to document what you're doing. You can't just say 45 minutes was spent with a patient. You need to describe what exactly happened in the encounter. The patient encounter took 45 minutes today to perform the following: take a history, perform the examination, review outside records, interpret imaging, counsel the patient on smoking cessation, weight loss prior to surgery, the risks of this surgery and exactly what that entails, other findings, and your plan in the EHR. So some level of detailed documentation is going to be required so that others looking at the chart can be able to analyze the amount of time or medical decision making you have put forward to establish the code level you've chosen. Next slide. So here is the reporting, the HCPCS code using 99205 and 215. You can see the red dots and asterisks at the upper level of time. So when you hit the 99205 threshold, which meant you spent 60 to 74 minutes performing that service, you go beyond 74 to hit the 89 to 103 15-minute increment, and that allows you to code for one 99205 service and one add-on G2212 service. You then go beyond the next 15 minutes to the 104, 118, and that allows you to have your 99205 primary service and 2 increments of prolonged services. You go to 119 minutes, and then beyond that, each 15-minute increment allows you to code for the amount of services, the amount of time you have provided, or the number of add-on increments of G2212 you've provided for each additional 15 minutes. So again, do not report until 15 additional minutes beyond the maximum time required for the primary procedure. On the established patient side, you see at 99215, it is a range between 40 and 54 minutes, but for the G code, it does not become active until you've reached the 54 minutes. So you add 15 minutes to that and you get 69 to 83 minutes. And that means one 99215 primary service and one G2212 add-on increment of prolonged service. And then as you go, each 15-minute increment allows you to add more add-on increments of prolonged services. Next slide. So when using 99417, we are at the minimum required time of the primary procedure. So for the 99205, it becomes effective at 60 minutes. So once your prolonged services, once you provided 75 minutes, that 1 minute above the maximum, you are into the first add-on increment. So between 75 and 89 minutes, you've reached your 99205 threshold, which ends at 74, but begins at 60, and you're allowed to apply one increment of 99417 prolonged service. 15 minutes beyond that, and you are at the 90 to 104 minutes, and then there are two increments. Beyond 105, it's 3 or more, depending on each 15-minute increment that's reached. On the established patient side, 99215 begins at 40 minutes. So you use 40 minutes as your start point for the 15 additional minutes for prolonged services. So beginning at 55 minutes, you can count the prolonged service of 99215 added on with one increment of 99417. 70 to 84 minutes, that's two increments of 99417. 85 minutes or more, 3 or more. So it's confusing, and you're going to have to look at these charts and kind of ingrain it in your mind until we get some resolution as to how these two potential prolonged service coding structures are going to be adapted by the various payers. Next slide, please. So just in summary, for our office and outpatient E&M coding changes for 2021, new patient services 99201 has been deleted. For established patients, 99211 is now below the level of provider or qualified healthcare provider. They all require medically appropriate history and physical only, no documenting each element, and extensive review of systems and all of those other guidelines. They both require straightforward, low, moderate, and high levels of medical decision making. They both have time ranges that have a threshold time that is met between each level of service. It's no longer an average time that you just take into consideration when you're performing medical decision making. Time is used as its own construct for coding, so you can use either medical decision making or time, and the various increments are as listed in the graph. And then when you reach the upper level of either 99205 for a new patient or 99215 for an established patient, then you can apply the prolonged services codes to account for the additional time utilized when coding on the basis of total time on the date of the encounter. Next slide, please. Well, I think we've come to the end. We want to thank everyone for participating in this webinar. A recording of the webinar and the PDF of this updated slide deck will be available on the ACS website at the link above. For more information on the 2021 Office and Outpatient E&M Coding Rules, see facs.org, E&M Coding. The handouts are available on the site. Please stay tuned for our future ACS webinars on E&M coding, including the implementation tips and policy updates that will be out sometime in March, and early learning lessons and frequently asked questions, which will be available in the summer of 2021. We're going to have a little bit of time for questions. You can also access our frequently asked questions on the ACS E&M coding website.
Great, thank you, Dr. Barney and Dr. McNally. Our first question is, if a patient is referred for possible major surgery and the surgeon decides that surgery is not appropriate based on their evaluation, would this still be considered a decision for surgery under risk?
Yes, this scenario applies to the medical decision-making element, risk of complications and/or morbidity or mortality of patient management, which includes possible management options selected and those considered but not selected after shared medical decision-making with the patient and/or family. For example, a decision about hospitalization includes consideration of alternative levels of care. Shared medical decision-making involves eliciting patient and/or family preferences, patient and/or family education, and explaining risk and benefits of management options.
Our next question is, if a surgeon is using MDM to select an office E&M code level, can they count activities related to the visit that's performed on a different date? For example, reviewing imaging results with a radiologist 2 days after the visit.
Yes, the restriction regarding day of encounter only applies when code selection is based on time. If you're using medical decision-making to select the code level, then you may count activities that are performed on days before or after the office visit, such as talking to the radiologist about an imaging report.
Our next question is, does the surgeon pick whether to bill medical decision-making versus time, or do both count now?
Medical decision-making or time may be used to select the level of office visit code for a single encounter, but not both. However, you may use medical decision-making for one patient and time for another patient. Or one time when you see a patient, you could use medical decision-making, and the next encounter you have with the patient, you may choose to use time. So you don't have to select one way to code for every time that you code.
Our next question is, at the CPT symposium, the American Medical Association said that each unique test can only be counted once when it is ordered. Is that correct?
That's a great question and a great clarification that needs to be made. CPT coding guidance states that ordering a test is included in the category of test results, and the review of the test result is part of the initial encounter and not separately counted at a subsequent encounter. However, if the surgeon is reviewing test results at a subsequent encounter and that prompts the physician to order additional tests, the ordering of additional tests does contribute to the medical decision-making for that subsequent visit.
Our next question is, What is the definition of major and minor procedures?
When considering medical decision-making, the classification of surgery into minor or major is based upon the common meaning of these terms when used by physicians. These terms are not defined by a global payment package classification, i.e., it doesn't matter if the global is 0, 10, or 90 days. The surgical qualifiers, elective, emergent, urgent, describe the timing of a procedure. Both elective and emergent procedures may be minor or major procedures.
The next question is, should outpatient consults continue using the 1995 or 1997 E&M reporting guidelines, or can a surgeon report using time?
For 2021, only the office and outpatient E&M codes 99202 through 99215 have been changed to allow reporting using either MDM or total time on the day of the encounter. For all other E&M codes, including outpatient consultation codes, as well as all of those inpatient, emergency medicine, domiciliary, and nursing codes, the 95-97 documentation guidelines still apply.
And this is our final question. Does the time-based billing include time spent documenting clinic notes?
Yes, all time, including non-face-to-face documentation time, applies when using time to select a level of office E&M code. The only requirement is that the time must be on the day of the encounter.
Thank you. Those are all of the questions for tonight.